Hey everyone, it's Denise Brown from the Caregiving Years Training Academy. Thanks so much for being with us today. This is our fourth day of Care and Share Our Big Ideas. We've got another set of ideas for you. Bobbi's going to go first. I'm going to go second. Then we're going to open up the conversation in the chat room. And for any who'd like to add their voice to what we're sharing today, just a reminder that if you are looking for CEUs, look for the evaluation form on Friday afternoon. Fill that out, send it back to us, and then 5 business days from receipt of that evaluation, look for your CEU certificate. We do want everybody to share their feedback though, so even if you're not looking for CEUs, please take some time to fill out that evaluation form. It's so helpful to us. Okay, Bobbi, take it away.
Good afternoon, everybody. Denise, thank you so much for hosting this entire event and for all of you joining us today. My big idea is to talk about what every patient must have an approved essential caregiver. Isolation is killing our carees. And although I mainly speak about dementia and dementia care, this need for an essential caregiver is not only for people that are in assisted living or memory care. I have long believed that every patient sick enough to be in the hospital should have an advocate with them to make sure that the hospital staff and the healthcare workers wash their hands between rooms to make sure dietary restrictions are followed. But before I get really in depth into this, I'd like to share a horror story that happened in our family just this year. Earlier this summer, my son-in-law was riding his bike near home when he was hit by a car. It left him lying in the road, covered in road rash with a severe head injury, 9 broken ribs, and a broken collarbone. When I got the call from my daughter that this has happened, my husband and I rushed to the hospital to be with her, where the 3 of us stood outside in the parking lot for 3 hours, wondering if he were still alive or what his actual condition was. But that's not the worst of the story. The really bad part happened the next day when he was lying in bed with only a blanket over his groin area because his skin was so damaged from the road rash. And he had a pillow under his arm to keep that broken collarbone in place because no bones had been set. When a nurse came in and he asked her to help him adjust that pillow because it had slipped out of place. At this point, she told him, no, do it yourself. When he explained that he couldn't, she grabbed that arm, lifted up over his head, moving that broken bone out of place, and shoved the pillow into those broken ribs. Now that situation has been dealt with, but it never would have happened if a family member or an essential caregiver had been in the room with this person. I've heard of other instances, say a gentleman with severe Parkinson's on blood thinners was handed a razor in the hospital to shave himself and ended up with dozens of cuts on his face. Again, this would not have happened if there had been an essential caregiver in place. And very often it's not because healthcare professionals are uncaring, it's often because they're overburdened, overworked, and understaffed. So having said that, you know, anybody, you can end up in the hospital with the flu, you can have a heart attack, you can have cancer, a child could be in the hospital. We need to have essential caregivers admitted with every single patient. So now I'm going to move on to what an essential caregiver is. Right now, we know thousands of dementia deaths are due to failure to thrive in our elder care facilities. Numbers that I've seen is as much as 11,000 throughout the summer. And what happens is these carees are trapped alone in their rooms and they don't understand why they're all by themselves. They don't understand where their family members are. They could be wandering around in that room. They're at fall risk. And they don't understand where their family members have gone. Have they been abandoned? Where did everybody go? There's no one there to hold a hand, no one there to offer a hug. The activities that keep their minds as active as possible have gone away. There's no music, therapy, there's no art therapy, there's no friendships. Our vulnerable loved ones are eating alone. And the result is now, it's what's now being called mortal loneliness. People who are relatively healthy physically at the start of COVID are now wasting away. So I imagine the first question that people might ask is, who is an essential caregiver? And that's a really easy question to answer. It's a person given consent by the patient or the resident or his or her representative to provide assistance with activities of daily living, bathing, dressing, eating, and to be there for an emotional support. And these are things that family members were doing in these facilities prior to COVID. Now they can't, which adds to the healthcare workers, again, being overburdened. So it could be a spouse, a husband or wife, an adult child, a brother or sister, a parent. It could be a neighbor that that you trust. Anyone over the age of 18, given consent, could be an essential caregiver. It doesn't take a great deal of training. And it's absolutely critical to the welfare of our vulnerable loved ones. Now, of course, there are guidelines for essential caregivers. Each patient or resident or his or her representative may designate up to 2 essential caregivers. Now, only one goes into the facility at any given time, unless it's at end of life. And then they can have more than 1 essential caregiver in there. And this second item is the one that I think is so absolutely important when we have essential caregivers going into these facilities, that they are not required to maintain social distancing from the resident or patient. They have to be allowed to touch them. They have to be allowed to hold their hand. Human touch is so important to us and to our mental and physical health. Now, they will maintain a distance of 6 feet from the staff and the other patients, but for their caree, they'll be allowed to touch them and give them massage, rub lotion on them, all of these things that are so important to us. And again, the essential caregiver has to be at least 18 years old. Essential caregivers should be allowed to visit the facility regardless of whether the facility has had a COVID-19 case in the last 14 days. And this is important because a number of facilities are using that as a reason to keep the family members out of the facility. And visitor testing could be required by the facility, but only when it's paid for by someone other than the essential caregiver. Again, some of these places are using the need for COVID testing to keep family members out of the facilities. Some have even asked that the family member be tested before each and every visit and tried to make them responsible for paying for the test and charging as much as $750 per test per visit, which basically said, you can't afford to come in here. It's another way of keeping people out. There should be certain guidelines for the facilities themselves. They should have sufficient staff to support the management of visitors. And visitors won't be coming in willy-nilly. They will come by appointment, maybe once a week or twice a week, at least enough to go in and speak with the caree and help them to the best of their ability. The facilities must provide infection prevention and control training to the visitors, including proper use of personal protection equipment, hand washing, and social distancing. None of this is hard. Most of us already know, we've heard over and over, wear your mask, wash your hands, don't touch your face. We know this. And another item is the residents may leave the facility for healthcare services and they must wear masks while they're out. And they're not required to isolate upon returning to the facility simply because they went to a doctor's office. And again, this is one of the reasons that some facilities and their managers are using to keep family members and essential caregivers out. And you know, to me, it's kind of disconcerting because the family caregivers and the families of the Carees have done a lot of work that these healthcare workers depended on pre-COVID. And now because they're not there, they're not getting the assistance that they need. So my call to action on this is follow and friend on Facebook, Caregivers for Compromise. And Caregivers for Compromise was started by Mary Daniels, who actually took a job in a care facility as a dishwasher so she would be allowed to visit her husband of over 50 years. The facility that he was in, they did allow the window visits, but they were so confusing and so upsetting to him and to her. She had to find another way to deal with this. So she started the Caregivers for Compromise, and she petitioned the governor of Florida to initiate a plan to work with care facilities to put in place a law to authorize essential caregivers designations for the protection of in support of the most vulnerable among us. It has now grown into a movement in every state in the United States. So the call for action is to please help. Like I said, this presentation is based on the program developed and fought for by Mary Daniels, who took a job as a dishwasher to spend time with her husband in a care facility in Florida's Executive Order 2052. Mary Daniels started this movement of Caregivers for Compromise.
Bobbi, you're at 10 minutes. So one last thought.
It was perfect. Go to these websites and sign up. And thank you very much. I also have a handout that I sent to Denise, and you can get that off the website eventually.
Yes. So all the archives and the PowerPoints and the handouts will be available on Monday, the 12th. So if you stop sharing, Bobbi, I'll go ahead and there we go. Excellent. We're doing such a great job with our transitions. Okay. All right. Everybody can see my screen? Okay. So I wanted to share an idea for a fall squad. So we know that falls are common during a caregiving experience. You probably have experienced falls with family members, falls with your own clients. There is a cost to the fall. And what's interesting is that it is Medicare, Medicaid, and private payers who absorb the cost. So it's not just Medicare and Medicaid. Typically, we would think those were the two organizations that would be absorbing the cost. But we also know there's a cost to the family, there's a cost to the family caregiver, and there's a cost to the caree too. In my own family, my mom started falling about 25 years ago, unfortunately. Her last fall was in June. Nothing significant happened. She just kind of wilted. We were able to get her up. She's okay. We do the once over and then we kind of just move on. But after going to my parents' apartment and helping them both up from the floor on a pretty regular basis, it occurred to me, who's going to do this when I'm not there? My parents are not willing to call 911 because they don't want to go back to the hospital. So that's a concern. Their wishes are to stay in their apartment regardless of what their declines are. So how do we accommodate people who want to stay home but yet are falling? Okay, so here's my big idea. It's a fall squad, and it's members of the community that help when someone falls. And they might be called something like fall response experts. The volunteers go through a training program. They learn safe techniques and they receive PPE. So that safe techniques include lifting someone, doing a really basic overview assessment, not giving any kind of diagnosis, not recommending any treatment, but just giving an overview of, okay, looks like you have a broken bone, we need to call 911. In addition, families enroll in the program. So as a family, my parents, myself, and my siblings would enroll as participants. And as participants, we would receive training as well. We would receive training on COVID precautions so that if the fall squad comes to my parents' apartment, we're ready for them. We've taken precautions. Perhaps I've opened up all the windows. I've put my mask on. I've done what I can to ensure that everybody remains as safe as possible. In addition, we're trained on fall prevention strategies. We also talk about the impact of falls and what regular ongoing falls could mean as it relates to someone's decline and how closer they're becoming to end of life. And in addition, as families enrolled in this program, we also receive PPE that we can keep ready to use if and when necessary. So as I was thinking about this, it occurred to me that there's a trauma after the fall. We often look to the Caree as having something traumatic happen, and sometimes that trauma means there's a visit to the hospital, even though we do whatever we can to keep them home. But there's a trauma for the family caregiver. So my mom took a terrible fall in December of 2014. We were at my sister's house. My mom wasn't feeling well. At that time, she was driving. She said, you know, I'm going to go home. And we all said, I'll take you home. Everybody volunteered to take her home. Leave the car here. We'll come and get you, the car tomorrow. No, 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 I am fine. She said, I am fine. And so we all just respected her decision. She left the house and I stood at the glass front door to watch her. And so I watched her feet get caught. I watched her hit the concrete. I watched her head hit the concrete and she was out. She passed out because of the concussion. So then when I ran to her, blood all over, we had to look for teeth. We had to look for hearing aids. We were trying to stop the blood. We got her back into the house. We did go to the hospital. They did a CAT scan. Everything was fine. She went home. If you can believe it, my mom went home that night at 1:30 in the morning, bloodied and bruised all over her face. And she sat and made out the grocery list for my sister because she wanted my sister to go to the grocery store later in the day, in 6 hours. Anyway, when I think about watching her fall, it was absolutely traumatic. I couldn't sleep for weeks because as I was falling asleep, I was thinking about, oh my God, what if I didn't watch her? What if she had fallen and we didn't know for hours? What if she had actually made it home but fell in the driveway and laid out there for hours? What if? That's the hard part about caregiving is we want to prevent so much. When something happens that we can't prevent, we revisit it thinking, oh my gosh, I wish I would have prevented this, even though that's impossible. So what if, as part of the fall squad, there actually is follow-up with the family? There's a certified caregiving consultant or social worker or some other mental health professional that talks to the family. It could just be the family caregiver, but it could be anyone who witnessed the fall. And then there's a conversation about, tell me what it was like for you. Share what that experience was. So we get to talk it out with someone who understands. And then we talk about, okay, what could we adjust and tweak? This happened. We know it happened. What could we do in the future? So moving us from, oh my God, I should have prevented it to, oh my God, this is what I can do in the future. And then maybe a couple little tips on training. So for instance, when my mom hit her head, I knew that she probably shouldn't move, but when she came to, it seemed like it was okay to move her. But just those kinds of tips would be really helpful. And then the reality check. And I think about this as it relates to my aunt. I did my best to visit my aunt every week during the last few years of her life. She lived in independent living and she fell all the time and they were always calling 911 for her. And her family, her children, my cousins, were terrified of a call from the facility that said, she can't live in an independent living anymore. She needs to move to assisted living. But they didn't want to talk about it with their mom, my aunt, who did not want to move. So finally what happened is she had a significant fall, went to the hospital, and they wouldn't readmit her. They wouldn't let her go back to the apartment. But what if, When we are enrolled in this Fall Squad program, as families, not only do we learn about how to manage when there's a fall, but talk about what happens because of falls, that there's a decline, that it's a progression of a disease, and that sometimes there has to be difficult decisions because of the falls. And what if someone like a certified caregiving consultant has that conversation with the family members when the falls really continue, so that the family's members can then have another conversation with a facility, for instance, about what's next. Oftentimes we know that it's a crisis that leads to a decision that leads to more help or a change in care setting. But what if that crisis isn't just taking everybody by surprise? There's a crisis and there's, oh, okay, we learned about this, so now let's talk about it. So that reality check can lead to maybe some changes in the amount of help and support. Now, I know that it's so much easier said than done, but it's that conversation and that process that can start, that can help. So what if, when I enroll, for instance, to be a recipient with my parents of the Fall Squad, I also am a volunteer, so I help people in my community when there's a fall. I live in a suburb where there are a lot of older adults. For instance, actually across the hall from me, there's someone who's an older adult who is in and out of the hospital. What if I am part of her Fall Squad? I just walk across the courtyard and go help her. So who's going to fund it, you say? That is the big question. Who would fund this? So what if it is my suburb that puts aside some money because they save some money by not sending out 911 calls all the time? Maybe it's a Medicaid waiver program, or maybe Medicare and Medicare Advantage programs. And maybe we as a family pay to be a part of this, knowing that it keeps my family safer and that we have a solution that feels more reasonable than always calling 911. So here's my call to action to you. Thinking about who's on your fall squad. If you took a fall at home, who could help? And then how can you train and empower them so that if there's a fall, you know what to do? Okay. Those are our 2 ideas for today. So I'm going to open it up. You are welcome to share questions and observations in the chat room. If you'd like to unmute, please feel free to unmute. And I want to mention something about the Fall Squad. I really looked at it as community-based. I was thinking about how do facilities manage, and it feels like that is a bigger bear to wrestle given COVID. So I just really stayed with, in our neighborhoods, in our communities, what can we do to help each other when someone in the family takes a fall? Okay, so I'm just curious, when was the last time any of you helped a family member because of a fall? So mine was June. I'll be honest with you too, I worry about falling because I live alone. I'd love to have a fall squad that would come and help me.
Hi, can you hear me? This is Line Hina.
Yes, go ahead.
Oh, I did help my mom due to the diabetes. She lost her vision because of somehow her sugar shoots up like 300 something. So her BP went up, and she got shortness of breathing, and she couldn't see the stairs, so she fainted and she missed the steps, so she rolled over and fall down on the floor. And nobody knows about it until I walked in, and then I saw that she was in the, on the floor. And then I called 911 because somehow my dad called they have that service, which is he pushed the button because he doesn't have a leg, so he couldn't get up to get her up. So he pushed the button, and then emergency service keeps saying your call is unprocessed, but nobody was there until I opened the door. When I came in, I saw her on the floor. Then I called 911, and right away the ambulance came and took her in the hospital, and they said because of diabetes was very bad, and that's probably where she lost her reason, and all this happened. But that was a very scary situation. Lucky that she didn't hit her head or something. Otherwise, she could have interior bleeding and she could pass out. But she's still alive, and now she's again, doing good.
Yeah.
This happened with the COVID-19. Their diabetes is acting up, and they end up like at least this year 3 to 4 times in the hospital.
Yeah. That is so scary. And I also think your comment made me think about how hesitant our carees are to sometimes press their emergency alert button because they don't want 911 to come. So I guess the other problem that I have with my my big idea, now that I'm thinking about it, is how do we know when someone's fallen? So I know when one of my parents has fallen because the other one will call me. But when I fall by myself, how will someone know if I have fallen? So I have to think that through a little bit more with the fall squad. But maybe as a fall squad member, I create a phone tree. Maybe there's a phone tree that we create where we do regular check-ins, just 8 a.m., 8 p.m. Yeah. But I want to read a comment that Teresa has shared in the chat room around Bobbi's Essential Caregiver idea. So Teresa's writing, while I agree with you on many aspects of your big idea, I am a social worker in a skilled nursing environment. There simply isn't enough staff to have that training for what we could, Teresa, I'm just a little, I know you said that some of your comment got.
Sorry, I was trying to, sorry, that's my fault.
That's okay. I'm glad you joined. Go for it. Yeah, tell us.
I was hitting enter as I was trying to separate my thoughts, but then it was sending, and so I got everybody confused. I was just saying, so we had a COVID outbreak at one of my, at the facility that I previously worked at, and they're just, one of the things that Bobbi said was, about having the no social distancing and things like that for that essential caregiver. However, the residents in our facility are the so vulnerable, and this was back in March, of course, so there wasn't as much research as we know now and things like that. So of course, the visiting was all shut down, but we did virtual visits and we did the window visits. And while of course it wasn't the same, anybody that was end of life, we did allow them to come in so that they could hold their hand and they could hug them because likely they were end of life. So the risk of them even contracting COVID at that rate was kind of null and void, if that makes sense. But the other thing I wanted to mention is that there's just not enough, you mentioned about training for visitors for, infection control and things like that, but there just is not even enough staff for, as I'm sure everybody on this call knows, in a skilled nursing facility. And that's because of the Medicaid funding. That's because of the Medicare funding. It starts with the government. I mean, the CNAs don't get paid enough for what they do, and they're consistently working short staff, and they're consistently have, a higher, ratio of CNA to patients than they probably should. Sorry for my daughter in the background. So anyway, so sorry, that was what I was trying to get across, but like I said, I obviously was having difficulty typing.
That's okay.
So yes, I agree with everything you said, Bobbi, but then, looking at it from like a realistic standpoint as well, and I know that's why it's called, right, this is the big idea, but it'd be amazing if it was something that we could do. But I don't know that can happen, right, until like Medicare increases their funding or Medicaid actually pays the facility on time so that it's not consistently short. You know what I'm saying? It's this huge snowball effect.
Yeah.
Teresa, I really thank you for sharing your thoughts on this, because this certainly isn't an idea that is being universally embraced right off the top. But we're really not trying to make work for the people in the facilities. In large part, we're trying to help them, because the family members were in there and they were doing a lot of things for the carees in the facilities before COVID hit. And it's not to add an additional expense. it's in some ways to make it a little bit easier. And we don't expect that things as far as COVID goes in this country are going to change anytime soon, especially through the winter. And facilities are having, outside visits. Those are going to come to an end. And as far as the training goes, as I mentioned, you could put together a Zoom video that anybody who wants to be an essential caregiver can look at that and get that virtual training in that way. You don't have to have somebody to train each person individually. We would always want to work to make sure that it was as cost effective as possible to make sure that these very vulnerable elders are not left to, isolated and separated from family members and separated from human touch. But this is something that it's ongoing throughout the country, and different states are going to handle it differently. But if we don't put the idea out there, then nothing's going to happen. But again, Teresa, I certainly understand your concerns.
I want to mention that University of Illinois has been doing a really interesting testing pilot, I guess you could say, since July. And they're using the saliva test, and the students are required to do the saliva test twice a week. There's an app that displays their test result. And in order for them to gain entry into any building on campus, their classroom or their dorm, they have to show their app and that they've tested negative within a period of like 3 days. And they figured out testing twice a week is the most effective way to catch the infection early and decrease exposure. They did have a little bit of a hard time when the students came back to campus, as you can imagine, because of the parties, but it's leveled off. And so they've done something like almost 500,000 tests so far, and their positive rate is under 0.5%. I check it pretty much every day because I'm fascinated. So here in the state of Illinois, the Department of Aging is watching that, because that would be a way that families would be able to visit without worries. So they would just all do the saliva test before they gain entry. So it's something to watch about, keep track of, to see how well that does. I mean, there could be a possibility that in the winter, before any of us go into a building, restaurant, store, whatever, we do a saliva test to see if we are positive or negative. Okay.
Maureen's talking, but she's muted.
Oh, go ahead. Unmute yourself, Maureen. Thank you, Bobbi.
Okay,
My
sorry.
chat room's in the way. Yeah.
Okay, so some of the facilities though are starting to set up a room inside, preparing for the cold weather for the visits, where they're going to have to, keep it cleaned in between, obviously still schedule the visitors. And I see a client in a facility. Now, I'm not totally in the facility, but I'm in the vestibule, but hey, you're out of the elements at least to see them. So that's a possibility, but getting back to the whole fall squad thing, I was reading through the chats, and it makes sense, even if they have some kind of Alexa or some device to somehow notify the people of the fall squad, and which is good, because if they're conscious, that's probably a good place to start. Now, for those that are unconscious, of course, you want the emergency response team to come. It just depends on, whether they're really hurt or not, or they just truly can't get up by themselves.
Yes. And Bobbi is reminding me, she posted in the chat room, that we had a winner at our 3rd annual National Caregiving Conference who developed this great product that's easy to help people up from a fall. It's basically a harness that you wear and they grab hold, and it's easy for you to pick them up. I'll post a link to that product, because they demonstrated using me as if I had fallen. They picked me up. And it was really easy. It was embarrassing to be on stage and have that happen to me, but it showed that it really does work.
I saw a commercial today for this other thing, just if people have trouble getting up, like from the couch and chair, the other person is standing there holding it, and then you and the person trying to get up holds it. And somehow seems to work, or at least on the commercial it did. And it was only $19.99.
Yeah, and I think the handles that Bobbi referred are maybe 20, maybe 30 bucks, something like that, very low cost. So maybe part of the training is that you receive these products that you use, and maybe as a Fall Squad member, you have a t-shirt and maybe an apron, and in your apron you have, you know, the products that you use in your pockets, and then you're ready to go.
Yeah.
So yeah, Heather has a question for you, Bobbi, in the
Okay.
chat room. So she's writing, my mother's in a memory care facility at this time. I've been working with the facility to allow me, with training, PPE, testing, anything, to visit with her in person, to do her nails, give her a back massage, spend time with her as we used to. The facility reports that they have to abide by the CDC guidelines or face shutdown, so they cannot negotiate anything with me. It seems like we need to change the CDC before anything else can change. Any thoughts?
I think it's going to take time, and you know, this is all time sensitive. It's really difficult. But what the Caregivers for Compromise are doing is encouraging people and giving them letters to go forward to send to the individual governors to get the law changed within the state. How those laws work with the CDC, I don't know. But more and more states are beginning to open up, and in the handout that's going to be available, there's a link to some of these letters, and there's a link to the action that was taken in Florida, where the governor actually stood up in front of the TV cameras with Mary Daniels and talked about how they work together and how important this issue is. But I'm sure there's going to be some blowback, and some of it's because it's a misunderstanding of, we're not just saying open the doors and let anybody in any time of day, that kind of thing. It's definitely by appointment. There's only one person, that's allowed unless it's an end of life thing, and everybody's going to work to make it as safe as possible. But this failure to thrive issue, it really is killing people. And especially in the memory care facilities where they just don't understand what's happening. And again, at one of the conferences, I was on a panel with a woman from the United Kingdom, where they have a program in place where people with dementia are assigned basically an essential caregiver, because the health industry understands that they cannot respond to the questions. They are not responsible to listen to the guidelines and to follow directions any more than children are. And I hate to refer to people with dementia as childlike, but as far as it comes to decision making and looking out for their own safety, they need somebody to be there for them.
Very true. There's a whole other population too. Clearly, it's horrible for anybody that's in a facility and unable to have the visitation, but there are nursing homes for the mentally ill. So they are not, they do not have dementia. They're cognitively aware, and they are just as restricted. And I don't know which is worse. I think it's horrible for everybody. But they do know and remember, all the time, and yet can't get out and can't have the visitation either, any more than the restrictions that, the other facilities have.
And like I mentioned in the beginning, it doesn't have to be a facility. It can be in a regular hospital. And you need to have an advocate there with you.
So true.
Yeah, it really speaks to the tremendous problems and challenges that we're facing today, and how do we work through them. Now, I know CMS did create a expert panel to address the issue. I did not read their findings or their recommendations. I read yesterday that one of the experts on the panel dissented. So I guess we can all go and look and see what they recommended in order to keep any kind of spread or surge within a facility down. But I guess I always am a little concerned about money being spent that way. Even if they are not reimbursed as experts on a panel, there's money still being spent on that. And it seems to, I think it was Teresa who talked about how hard it is as a facility to manage the budget. Money needs to go to the facilities. Money needs to keep PPE in facilities. Money needs to reimburse the facilities so they can pay their staff more. One of the problems with facilities is that there oftentimes are staff members who work at different facilities. So they are going from one facility to another and their exposure is great. And then they actually are exposed in one facility and then go to another facility and that facility is exposed. It seems to me like the money really needs to go to the facilities to pay the staff so that they don't have to work other jobs and so that the staff does not have to scramble for PPE. I mean,
I know, it was horrible. It was horrible in the beginning. And the people that were so sick with the COVID and the staff taking care of them, putting themselves at risk. And we've lost quite a few, the 212, 13,000 deaths. A lot of them have been healthcare workers.
they also do know that community spread and spread in a facility are directly related. That
Absolutely.
it's not just a coincidence when both happen. So we certainly have enough data to point to what can we do within a facility to help the facility. Yeah, it's
horrible. And with the residents on lockdown, it's the staff bringing it in.
Yes. My
Right.
daughter-in-law is a cath nurse in Florida, and she talks about that frequently, about having to go from facility to facility, and some of them are safer than others, and it puts her and the other nurses at risk. She's been in isolation 3 times.
I know.
Yeah. So I'm curious, who is on your fall squad as you think about creating your own personal fall squad?
Well, I'm with you,
Okay.
Denise, because I live alone. So I need to develop one.
Yes, I need to too. So I'm going to start being creative about who can be on my fall squad.
I can start with my sisters. One only lives 2 blocks from me. And I have some younger neighbors, so I can certainly get them, I think, on board.
Yeah, and even arm them with a couple products to help.
Right.
The helping handles. Yeah.
And hope that my fall days are somewhere further down the road.
Don't we all hope that?
Yeah, we hope that
But
this,
anything can happen at any time. So
right. We hope this is 30 years in the future. But I think just as we've been talking about all this week, it's really about starting to have a conversation with family about things that could happen. So not everybody is caught off guard. Even the conversation, Bobbi, about essential caregivers. One thing that came to mind when I was listening to you say, okay, who can be an essential caregiver? I would be for my parents, but I'm just going to be really honest and tell you that it would make me mad if I was the only one. Because I would say, you know what, come on. I need my siblings to be essential caregivers too. How do you think that will work out just in terms of family dynamics, Bobbi, about who gets selected and then what's that impact?
Oh, I can imagine that's going to cause all kinds of problems that we hadn't thought about before. But I think the idea of having only 2 with one going in each time was to reduce the burden on the facility and, not make them feel like all of a sudden they're going to be overwhelmed by a bunch of people coming in. But when it comes to families, we are very, very creative in finding ways to fight with each other.
Oh, yes, we do. I know. We just are just like our expertise on the dysfunction is really just amazing.
Absolutely.
So what if there's essential caregivers that are position per day, so to speak. So maybe I'm the essential caregiver 4 days a week, and then my sister is on Saturday.
That sounds absolutely workable to me. And again, I imagine that once we get through the governors to get it approved, you know, even within the state, then you have to go to the facilities and you have to have some leeway in working with them as well. You know, we're not going to go in there and say, okay, the governor said I can do this and you can't say anything about it. You have to be working with them as well.
Yeah, we have to take responsibility for the responsibility of being an essential caregiver.
Absolutely.
And know what is entailed in that. And that was one of the conversations that came out of the chat room. You know, it's ensuring that we are abiding by the policies,
Mm-hmm.
you know, but what's the liability if I don't? You know, if I'm just going out and having a great time at a party on Friday night and then Saturday I go to the facility, you know, we just have to be responsible. But, you know, we know that. I mean, we know that. We know
Right.
that. Yeah.
Sorry, this is Teresa. I just like to make another.
Oh, yes, go for it.
So to that point, Denise, you know, we had so many residents actually have their family members leave the skilled nursing facility or take their loved ones out because they couldn't physically be with them. Which, to be very honest, I can't say that I blame them, right? Because I mean, one, it was again in March, so we didn't know the full effect of everything, and so it was, you know, complete shutdown. But they couldn't come in, and they were these quote unquote essential caregivers who were there all the time. They were the family members that would come and bring them dinner. If the resident couldn't feed themselves, they would be the ones to feed them after work. You know, those types of situations. And they said, forget it, I'll figure it out at home, and you know, I need my loved one to be, and like I said, I can't say that I blame them, you know. So just another comment.
Yeah, and I think that people did that without having a lot of support or thinking it through because they felt they had no other choice. And that really is the worst kind of decision we want people to have to feel like they have to make. That I think that was the heartbreaking part about the entire situation, is there really was no win for anyone.
Mm-hmm.
Literally, everyone lost. And some paid a huge, significant price for this. And I think the trauma of this experience is going to last with us for a long time. You know, we are going to have that image of the window and then the two hands on the other side of that window seared in our mind for a long time.
Mm-hmm.
And I think in terms of the long-term care industry, you know, I think that it's they have a long road ahead, I think. And that's unfortunate. It's just unfortunate. It's hard when you feel like caregiving is really difficult and the good choices aren't there. It's even worse when you feel like there aren't any choices out there. And that's what happened with COVID. I think people really felt like there just wasn't a choice. There wasn't a choice about home health or facilities. You just had to kind of make do. And the other thing I think that we all worry about is we don't know what's going on in the homes. We don't know what people are really dealing with. We had talked about this, I think, yesterday. I can't remember which big idea it was, but I think Diana was talking about her home visits. Oh, we were talking about training after the hospital, and that you only really know what's going on when you see the caree and the family in their home. And I think that's also what we are not seeing right now. We don't necessarily know what struggles and challenges people are encountering in the home. And I also really worry about the falls in the facility. How's the facility managing those falls? And that's why I didn't go down that road of what's the solution in the facility. I just stayed with the community because I think, wow, I mean, the ripple effect is just tremendous, absolutely tremendous. Okay, so we have just about a minute left. Maureen, did you want to add anything?
I'm going to say in the facility, oftentimes if they've fallen, they will send them out just to get evaluated at the hospital. And the downside of that is they come back and they're quarantined again in their room, isolation for 14 days.
Yeah, again, it's just that there really is truly no good solution right now that we are figuring out. None. Even if you, well, anyway, okay. All right. Okay, Bobbi, any last thoughts before we close for today?
No, I just really want to know, I appreciate all of the input on this, because even what seems like a diversion of what the idea was helps refine that idea. And as always, in associating with the people in this group in that Denise brings together, always learn something. Thank you so much, everybody, and thank you, Denise.
Okay, thanks everybody for being here. We are finished with day 4. We have 1 day left, so I'll see you tomorrow. Same time, same place. Thanks everybody. So appreciate all your comments and insights and experiences. So appreciate it. See you tomorrow.
Okay, bye-bye.